Good morning, everyone. The topic of my presentation is frontal lobe, its functions, tests, and role in psychiatry. And my moderator is Dr. Veena. In this, we will be studying about the anatomy of the frontal lobe, functions of the frontal lobe, tests of frontal lobe, and frontal lobe role in psychiatry. Last slide. Anatomy. It is the largest part of the cerebral hemisphere. In humans, it reaches its full maturity around the late 20s. A small amount of atrophy, however, is normal in the aging person's frontal lobe. A decline frontal lobe volume of approximately 0.5% every year seemed to be average. The frontal lobe is delimited from the parietal lobe posteriorly by the groove called the central sulcus, and medially by the longitudinal fissure, and from the temporal lobe inferomedially by the lateral sulcus. From the temporal lobe, it is by the lateral sulcus, and from the parietal lobe, it is by the central. Functional areas of the frontal lobe. The first one is the primary motor area, the Brodmann area 4. It corresponds to the precentral gyrus. It contains a topographical organized map motor homunculus of the opposite body half, with head most laterally and leg and foot on the medial surface. The larger the area, it covers the smaller area, and the smaller part, it covers the larger area, and it is involved in the fine motor activities. Anatomically, these areas, the primary motor area, these gives origin to the projection fibers that form the corticospinal and corticonuclear tract. The second one is the premotor cortex, that is Brodmann area 6. It is in the front. The Brodmann area 6, it is in the front of the primary motor cortex. Direction selectivity for movement is common feature of the premotor neurons. Dorsally, the dorsal part, it acts on the internally guided movements, and the ventral part, it acts on the externally guided movements. Then the frontal eye field, that is Brodmann's area 6, 8, and 9. The stimulation of this area, it causes both the eyes to move in the opposite side, the conjugate movements. Prefrontal area, excluding the motor and the premotor areas, it predominantly comprises of the Brodmann area 44 and 45. Then the Broca's area, that is area number 44 and 45. Injury of this Broca's area, it leads to aphasia, that is inability to speak, even though muscles are not paralyzed. From the Broca's areas, the motor commands goes to the cranial nerve nuclei and the pons and medulla along associated with anterior and also to the anterior horn cells in the spinal cord. Nerve impulses then goes to the lips, tongue, palate, pharynx, larynx, respiratory muscles, which leads to the articulation of speech. When this Broca's area is damaged, then it leads to Broca's aphasia, in which there is difficulty in articulation, but the comprehension is not impaired. In contrast to that, the Wernicke's area, that is area 22, which is dominant in the temporal lobe. In this, the comprehension is impaired. Blood supply of the frontal lobe. The frontal lobe is supplied by the anterior cerebral artery. Anterior cerebral artery supplies the frontal lobe. This one, middle cerebral artery, it supplies the parietal and the temporal lobe, and posterior cerebral artery, it supplies the occipital lobe. Functions of the frontal lobe. First function is attention. Attention involves a large network, including the reticular activating system, thalamus, anterior cingulate, frontal, and posterior parietal cortices. Attention can be separated into sustained, divided, and focused. Sustained attention is the ability to maintain attention over a prolonged period of time. Divided attention, or the ability to simultaneously attend to different courses of information, relies more heavily on the right frontal activation. Focused attention, the ability to inhibit irrelevant stimuli, may preferentially involve the orbitofrontal lobe. Second is executive function. Executive function enables the performance of purposeful, goal-directed behaviors. Effective performance necessitates volition, planning, selection, sequential organization, and self-monitoring of action. Volition refers to the ability of an individual to perceive his or her needs and to have the motivation to act on these needs. Impaired motivation has been associated with lesions of the anterior cingulate and dorsolateral prefrontal cortex. Planning requires the ability to look ahead in time, generate hypotheses for future events, select relevant actions according to the context, and sequence the actions needed to accomplish a specific goal. Moreover, facing novel situations require the ability to change a plan. Patients with frontal lobe dysfunctions have shown deficits in both planning and decision making. Recent evidences suggest that isolated planning impairment on a complex multitasking test, the Greenwich test, was associated with lesion of the right dorsolateral prefrontal cortex. Many conceptual frameworks of executive functions have been proposed in the literature. For example, the schema used above, volition, planning, execution, and self-monitoring, was suggested by Luria based on the clinical observation. Chalice suggested that a supervisory attentional system located in the frontal lobes modulates the largely automatic and overlearned abilities under the influence of posterior sensory motor areas. Another view is that there are many frontal functions divided according to their hierarchical levels and interacting with posterobasal functions. Third is memory. The executive functions mediated by the prefrontal lobes are also involved in memory. Although there is no frontal amnesia per se, impaired executive control over the memory system can lead to significant deficits when testing memory functions. Working memory, the temporary holding of information that is currently being processed, relies on the function of the dorsolateral prefrontal cortices and as a result is impaired following the lesions of those areas. Deficits in learning and long-term memory are also following frontal lobe lesions with severity varying according to the task demands. Tests that require planning and organizational strategies either at encoding or retrieval, such as wordless learning or recall of remote memories, are affected in frontal deficits. Functional imaging studies have suggested that left prefrontal areas are more involved in encoding of novel events in episodic memory, whereas retrieval of episodic information is mediated bilaterally but with a right hemispheric bias. Left prefrontal cortex is also involved in retrieval of information from semantic memory. The frontal lobe has also been shown to play a role in prospective memory, the ability to remember to do things in the future. The left medial prefrontal cortex may have a predominant role in prospective memory. Fourth is language. Two classic aphasia syndromes have been associated with dysfunction of the frontal lobe, Broca's aphasia and transcortical motor aphasia, TCMA, which highlight the role of the dominant frontal lobe in language. The left inferior frontal gyrus and operculum, Broca's area, are involved in assembly of phonemes into words and words into sentences, as well as in the grammatical structure of sentences. The frontal lobes are also implicated in other aspects of language. In particular, the right hemisphere have a predominant role in the modulation of prosody, the attitudinal and emotional melody carried by normal speech, and the elaboration of gestures accompanying discourse. Fifth is self-awareness. In the hierarchical model of frontal lobe functions, the highest level of function is the one of self-awareness and theory of mind. The sense of self as an entity across time necessitates the convergence of both memory and emotion. The Capgras syndrome, the belief that a significant other has been replaced by an imposter, is an example of failure of this convergence. Alexander et al. Reported such a phenomenon in a patient who had sustained bilateral frontal lobe damage, more extensive on the right, and who was convinced that a new identical second family had replaced his first family. The knowledge with respect to his family members was not accompanied by the emotional experience and the sense of warmth and intimacy that should have triggered those emotions. Knowing who we are is an essential step in the process of projecting who we want to be. The right prefrontal lobe has been suggested as a key area for recollection of past events with their associated emotions and connecting those with plans and expectations with the future. Theory of mind. Theory of mind refers to the ability to be aware of the thoughts and feelings of others and to make inferences about the mental states of others. Deficits in theory of mind has been associated with frontal lobe lesions. Moreover, different regions within the frontal lobe may mediate different aspects of the theory of mind. Test of the frontal lobe. First of all, the precursors to assessing prefrontal functions. The prefrontal lobe has been divided into dorsolateral prefrontal lobe, supromedial or orbitofrontal, and frontal poles. When performing a comprehensive neurological assessment, the clinician must first determine the basic neurological processes are intact before assessing more complex processes. In the assessment of prefrontal lobe functions, it is important to first determine that the patient is fully alert and not in a confusional state or delirium. For tests requiring motor responses such as drawing, writing, or tapping, it is important to determine the basic sensory motor functions are intact. Because many bedside tests of prefrontal functions rely on spoken instructions or verbal responses from the patient, it is important to determine whether the patient is aphasic. If language function is sufficiently impaired to make verbal responses or comprehension unreliable, the examiner should focus on tests that do not require language comprehension or a verbal response. If comprehension is significantly affected, most cognitive tasks, including the prefrontal task, will be difficult to administer since the patient may not be able to follow the instructions. First of all, the superior medial supromedial prefrontal functions. Dysfunction of the supromedial prefrontal cortex lead to deficits in energization to various degrees. Initially, this is assessed by history and careful observation of the patient. At one extreme, a very severe deficit of energization will cause akinetic mutism, a total inability to initiate any internally derived activity, but with intact basic sensory and motor functions and retained ability to reach to external stimuli. Although it is not difficult to recognize that something is seriously wrong when patients exhibit akinetic mutism, this rare syndrome can be mistaken for locked-in syndrome or a psychiatric illness such as depression. Less severe forms of energization deficit produce reduced initiation of motor, cognitive, or combined psychomotor responses despite preserved basic attention. The term abulia is often used to describe decreased initiation of cognitive responses. Apathy is the term used to describe a less severe expression of lack of initiation. In the history, the patient will often be described as lacking motivation, and this may be misattributed to a psychological crisis, psychiatric illness such as depression or even general fatigue. The first test is phonemic word fluency. It is also known as lexical word fluency, the ability to generate words starting with a particular letter. It can be a useful index of energization. To administer this test as an index of energization, it is important to first establish that the patient does not have aphasia. The patient is then asked to generate as many words that begin with a certain letter as possible within a defined time interval, generally 1 minute. Usually, the patients are asked to exclude proper nouns, numbers, and multiple versions of a single word, example, farm or farming. If the patient generates significantly fewer words later in the time interval, this is particularly sensitive to dysfunction of the superior medial prefrontal region as opposed to the other prefrontal regions. Second is the apathy evaluation scale. Apathy has been defined as an amotivational syndrome, and indeed lack of motivation will decrease speed of response. However, apathy may better be defined as a syndrome characterized by lack of initiation and drive, as it is clear that not all patients with abulia or apathy lack motivation in the sense of the will of act. The presence of apathy is usually determined by careful history taking. Here again, care must be taken not to confuse apathy with depression. Specific rating scales such as the apathy evaluation scale can provide helpful information in quantifying the degree of apathy. This is the apathy evaluation scale, which is self-rated, and it consists of 18 questions. which has to be answered by the patient itself. Second one are the lateral prefrontal functions. Patients with damage to the lateral prefrontal cortex demonstrate deficits in task settings and monitoring, both of which are components of executive functions. The lateral prefrontal lobes are also important for working memory, the ability to consciously retain and manipulate information in the short term. Such patients may be able to complete previously learned routines, but will have difficulty in carrying out something novel. In more severe cases, completing even more familiar tasks in a logical manner can be impaired. For example, a patient may previously have been actively involved in planning family vacations, booking hotels, and researching travel routes, but now the spouse does all of these tasks. Patients with lateral prefrontal lesions can have defective recruitment of procedures necessary for complex language assembly. They may speak in grammatically correct sentences with normal syntax, but the content may be described as vague or confused. The first is the digit span test. It is a simple test of working memory that is often used as a bedside test. In this test, the patient is presented with progressively longer strings of digits and asked to repeat them back in the same order as they are presented. Usually, the test involves allowing 2 attempts at a certain length of digits. Digit span backwards involve the patients having to repeat the digits in the reverse order and may be more reliant on lateral prefrontal cortex processes. The difference between forward and backward digit span, usually 2 or less, may indicate the degree to which executive functions are impaired. When administering digit span test, it is important for the examiner to present the digits at an even cadence, approximately 1 second apart, and to use consistent and neutral voice inflection, except for the last digit, for which the voice may be lowered to signal the end of the series of digits. Second is the Luria hand sequences. In this test, the patient are asked to place their hands on the table in a repeated palm, first edge sequence. Patient with basic difficulty in task setting will have difficulty repetitively and automatically performing this sequence correctly. A written equivalent that is commonly tested involves asking the patient to continue drawing a sequence of alternating connected squares and triangle-like sequence. Like here, the patient has we have given him a drawn square and then a triangle, but the patient, the dotted line shows what we have drawn. After the dotted line, the patient has drawn. The patient has drawn a triangle first and then a square and then a triangle and again a triangle. But what he had to do is he had to draw a square first and then a triangle and alternatively in a sequence. The multiple loops task is a related task that is more sensitive to deficiencies of monitoring. Patients are asked to repeatedly draw a series of 3 loops across a page like this. Patients with monitoring difficulties may either draw the number 3, like the patient has drawn here a number 3, which is a prepotent response, the action that has priority over others because of primacy during development, having been done recently or having the greatest relevance, or will continue to draw more than 3 loops, like the patient has drawn here more than 3 loops. Go or no-go task. In Luria's description of the task, the patient must raise one finger in response to one tap, that is go, but must not make any movement in response to 2 taps, that is no-go. A non-repeating sequence of single and double taps is presented, and the patient must respond appropriately throughout the sequence. Patient with difficulty in task setting will have difficulty in completing the task despite multiple instructions. Those with difficulty in monitoring will make errors. Fourth one is the conflicting instructions task. The conflicting instructions task is a modification of the go/non-go test task that is often administered in addition to it. In this task, the patient must raise 2 fingers in response to 1 tap and 1 finger in response to 2 taps. Fifth one is the trail making test. The trail making test is a popular test with myriad versions and is thought to be a sensitive measure of executive functions and lateral prefrontal cortex damage. In the most popular form, the patients are first presented a sheet of paper with 25 circles with the number of 1 through 25 printed inside the circles. This is the part A of test. Patient must connect the circles in correct order as quickly as possible without errors and our time. Part A is particularly sensitive to energization deficits, specifically basic motor speed and visual search speed, but this is also tests basic visuomotor attention and scanning. In part B, the 25 circles contain the letters 1 to 13 and the letters A to L. Patients must alternate numbers and letters in ascending order as quickly as possible without the errors. Thus, part B relies more on task setting, that is remembering to shift, mental set, and monitoring of errors than does part A. Like it is shown here, first there is a number and then there is a letter and the patient has to connect it in an ascending order. But the patient here has connected 1 to A, then A to 2. Then after 2, he has to connect B. After B, he has to connect 3, but the patient has connected C. Phonemic word fluency. Phonemic or lexical word fluency has already been discussed as a task that can be sensitive to medial frontal damage due to decreased energization, resulting in reduced initiation and production of responses. However, successful completion of this task also requires planning and searching as well as language processing. In fact, impairment in phonemic fluency is greatest in patients with left lateral prefrontal cortex damage. Seventh is design fluency. Design fluency